My name is Rebecca Vaux. I am Forefront Suicide Prevention's Communications Director. We're so excited that you're here today to join us for Autism and Suicide, What You Need to Know, which I think we could also title What We Need to Know, certainly what I'm interested in knowing. This event is part of our Forefront Speaker Series. We highlight subject matter experts who are working to reduce the risk of suicide and to support mental health in different populations. We are very grateful to the Washington State Department of Health who support this series. I think we probably have some first-time attendees here, so just a word about us here at Forefront. Forefront Suicide Prevention, are a center of excellence at the University of Washington, here in Seattle, Washington. We are housed in the School of Social Work. Our mission is to help people prevent suicide in their communities, and we do this in a few ways. First of all, we develop suicide prevention trainings that are tailored to the needs of specific communities, in particular for at-risk populations. Secondly, we educate on the dangers of unsecured firearms and medications in homes, and we give away free locking devices. Then we also work with high schools across Washington State to implement comprehensive suicide prevention programs. And we partner with state agencies and public officials, both as a trusted subject matter expert and also to disseminate learnings from our programs to a wider audience in Washington, across Washington. And we run a speaker series every year where we provide community education and professional development on suicide prevention, behavioral health, and related issues. And that's what we're doing today. We're really excited to have this subject. It's one we've been hoping to get for a long time, so we're super excited about this. A couple of quick logistics before I hand over to our presenters. The presentation will be just under an hour long, about 50 minutes. We'll include some time for questions at the end. Please try to put your questions into the Q&A, not in the chat. They tend to get buried in the chat, and we'll highlight some of those at the end. And we will also share a link through the Zoom chat at the end of the webinar for anyone who wants to request continuing education credits for this. You will have to fill out a small survey for that. There's a brief evaluation in that link. We tend to issue credits once a month, so it might take you a few weeks for those to get to you, but if you do complete that and you request credits, we will issue those to you after the survey's been completed. We're still finalizing the next couple of events in this series, so if you've signed up for our mailing list, we will notify you about those when we have them scheduled. And if you'd like to join our mailing list and you're not on it, that is accessible from our website. There's a subscribe link at the top and at the bottom, Forefront's website in the forefront.org. So, okay, I am really excited to introduce today's speakers. We have with us today Lisa Morgan and Caitlin Connor. Lisa Morgan, MSW, is a trauma-informed consultant specializing in crisis supports and suicide prevention for autistic people. She's founder and co-chair of the Autism and Suicide Prevention Work Group, and she's led the development of several autism-specific resources for communicating and supporting autistic people in crisis. She's a self-advocate with a passion for strengths-based solutions, and Lisa has authored several books, articles, and resources, which are all available on her website, which is linked from our events page, where you probably signed up for this to begin with. Lisa's a community council member of AASET, Autistic Adults and Other Stakeholders Engaged Together, and she has a master's in social work and in the art of teaching, is a certified autism specialist, a research consultant, and owns her own consultancy, Lisa Morgan Consulting, LLC. Caitlin Connor, PhD, LCP, is an assistant professor in the Department of Psychiatry at the University of Pittsburgh School of Medicine, and she's a licensed clinical psychologist. She's part of the REACT Lab, Regulation of Emotion in Autistic Adults, Children and Teens, which is housed in the Department of Psychiatry. Dr. Connor's research interests are in understanding, measuring, and treatment of co-occurring mental health conditions and suicidality in autistic teens and adults, and she's involved in several parts of a large Autism Center of Excellence grant focused on mental health and suicide in autistic adults, including co-leading a project to develop a self-report measure for the propensity of suicidality in autistic people. They're going to talk to us today about autism and suicide, what you need to know. As I said before, please put your questions into the Q&A. We will take questions at the end. We will make sure that we have some space for questions at the end. Thank you very much. Lisa and Caitlin, over to you.
Okay. All right, thank you guys so much again for having us. I'm Caitlin Connor, and I'm presenting today with Lisa, as Rebecca already mentioned, about autism and suicide. So I will see if I can move my slides forward. Okay, so of course, this is probably not new to this series, but just generally speaking, when I present on this kind of topic, and Lisa does as well, we typically make sure to say first, that you don't need to continue listening to this chat or this talk today. It's going to be recorded. We can send you slides. Please take a break or sign off if you need to, and take care. And of course, always you can use the National Suicide Hotline here in the US, 988, which does have a chat and a text function as well as a call function. We always, want to make sure that folks are feeling safe and okay with the information being discussed. I saw this already in the chat a little bit. So you guys were in front of us about language. So in this talk, we're going to be using identity first language when we refer to autism, so autistic people. I know typically, and this is how I was trained and as a sibling, how I was kind of raised was to say person with autism. And so I understand that people will still often say that. However, when we have done research in the last few years, and just from talking to autistic adults, they generally, mostly, at least the majority, prefer what we call identity first language. So autistic person, like they are autistic people. With the idea that, as this great illustration that Lisa provided, we're not necessarily saying someone is on the spectrum or, autism is something that's they're carrying with them or that they have, but instead, like, it is part of who they are. I would say though, however, and this is what I usually say to anybody, whether they're a mental health provider or anyone else, is that I always tend to ask a person what language they prefer. Do they prefer autistic person or person with? If I'm working with them, if I'm talking with them and their families, like that's generally where I'm going to go, because not all people prefer autistic, and some still use a person with autism. So just some information generally for this talk, we'll give autistic person. So Rebecca already did a great job of introducing both of us. Like I said, like she had said, I'm at the University of Pittsburgh and a clinical psychologist by training. I'm also a family member of several autistic people. And Lisa is an amazing consultant and person who has really worked in this field of autism and suicide and getting this information out and training individuals. And she actually trained our entire research team when we started our large ACE study, which was super helpful. So I wanted to make sure that she was presenting because she, I think, really is able to break these things down very well. Just really quick disclosures. We don't have any personal disclosures or anything like that to discuss. That big Autism Center of Excellence grant that I am part of that funds my salary is listed here, as well as a small one from the Edith L. Trees Trust that we use for developing our measure. And I always want to give credit to my colleagues who help with illustrations. Okay, I'm going to pass it over to Lisa to get started.
Thank you, Caitlin. Hi, everyone. Today's learning objectives are going to be talking about how to understand suicide statistics and warning signs. For autistic people, be able to explain unique risk and protective factors for suicide thoughts and behaviors in autistic people, and to adapt communication strategies to effectively assess suicidal thoughts and behaviors in autistic people. So first, I'm going to talk about what we know about autism and suicide. So we know that autistic individuals are significantly more likely to think about, attempt, and die by suicide than the general population. We also know that suicide is a leading cause of premature death for autistic people, and that is across the lifespan. We don't know as much about protective factors for autistic people, potentially social connectedness. There's also developing a list of reasons for living, but we need more information about that. We know autistic people have unique risk factors of suicide, which I'm going to talk about a bit more later. Warning signs of suicide are different for autistic people. And then interventions don't often make space for how autistic people think, communicate, or experience the world. Autistic people need interventions that are developed specifically for autistic people. And then statistics for autistic adults without an intellectual disability, the lifetime occurrence has been reported to be up to 66% of autistic people having suicidal ideation. A study done by Cassidy et al. In 2014 reported that 60% of the newly diagnosed autistic adults in that study reported suicidal ideation, compared to 17% of the general population in that study. As well, in the same study, 35% had planned or attempted suicide, compared to 2.5% in the general population. Also, autistic adults who are diagnosed later in life have the highest prevalence estimate. They have decades of not fitting in, challenges with communication, finding employment, executive functioning, feeling like they don't belong in the world, and not knowing why. When they're diagnosed, they have grief about their lives and what their lives could have been if they had known, and they can't go back and change it. So it's really difficult. And then autistic adults, if you could go on to the next slide, please. So for autistic adults with an intellectual disability, they are also more likely to attempt to die by suicide than the general population. There's a lower occurrence of suicidal ideation than with autistic people without an intellectual disability, which can make it even more difficult to understand that they are suicidal. As well, there's more difficulty with communication and poorer access to services. So we need a lot more research to understand this population, understand their anxiety and depression as well. And for autistic children and adolescents, autistic children are 28 times more likely to think about or attempt to die by suicide than their peers. And one study showed suicidal ideation and behavior had been reported in autistic children under 10 years old. And then Kennedy Krieger Institute came out with a study last year in April of 2024. They had 900 responses by caregivers of autistic children. And what that showed them is that 40.5% reported they wanted to die, 19.3% reported they wanted to end their life. That together is 59.8%. And then 7.4% reported having a plan. And some of these autistic children started experiencing suicidal ideation at 8 years or younger. So it's really across the lifespan. And as far as, being diagnosed later in life is really anytime after the age of 18. But there are some autistic people who are diagnosed later in life, because I saw a question in the chat, in their 50s, 60s, and 70s as well. So it truly is across the lifespan. Next. So now we're going to discuss risk factors and warning signs of suicide for autistic people. So first, I want to just say that this list is not all of the suicide risk factors for autistic people. It contains some of the most studied and supported. There's also thwarted belonging, aloneness, and a diagnosis of autism itself is a unique risk factor. So the first one, co-occurring psychiatric conditions. There was a large study in Denmark. It was a big national study. Co-occurring psychiatric conditions were found to be a major risk factor, with more than 90% of those on the spectrum who attempted or died by suicide had another co-occurring condition, with anxiety and affective disorders like depression being the most common. Then, as far as lack of social support and unmet support needs, if you could click. So unmet support needs, it's really asking for help is a social skill. So it's reaching out for help can be very difficult. They may have never done it before either. We also have evidence that lack of social support and unmet support needs in autistic adults significantly predict suicidality, even after controlling for a number of demographics and diagnoses. So they may not even understand what to reach out for or what to ask. Unmet needs was defined broadly in the Cassidy et al. Study. So it could be anything from mental health concerns to employment, housing, education, healthcare, that's physical healthcare, finances, social activities, relationships, higher education. I mean, it goes on and on. It's really the number of unmet support needs. Could you click again? And one more time. Whoop. So yeah, so masking and camouflaging is the next one. And we can go right there. Yep. So masking or camouflaging is a social strategy whereby autistic people attempt to camouflage or mask their autistic traits in order to fit in and have that, you know, positive social interaction, get that job, have a relationship. But research has shown that masking or camouflaging may negatively affect the mental health of autistic people, increase the risk of non-suicidal self-injury and suicidality, even after controlling for a number of demographics and diagnoses. The cost is, it's so exhausting to mask. There's a lack of sense of self. There's a lack of support, because when you reach out for support while you're masking, you're getting the support of a non-autistic person because you're masking as a non-autistic person. And then not being known for who you really are. People don't get to know the person behind the mask because they're masking completely. So again, it helps autistic people to socialize, but then it also can hinder relationships because it can cause difficulty if, as a relationship moves closer and an autistic person starts showing their traits, that can cause difficulty of, you know, you're not who you were when I first met you kind of thing. And all in all, it really can lead to profound loneliness and of not belonging, which goes into that thwarted belonging piece. Could you click again? And then one more time.
You want to keep going?
No, we're going to talk about late diagnosis.
Okay.
So late diagnosis can be related to unmet support needs and masking. There could be a lot of grief, like I said before, experienced by autistic people diagnosed later in life. They mourn what they could have had if they had known sooner. They have regrets. And then females are also, being female on the spectrum is also a unique risk factor. Autistic females are at a particularly high risk, as a matter of fact. Research studies have shown the rate to be up to 13 times higher than non-autistic females. Many experience being misdiagnosed, and that invalidation about what they were experiencing and not believed about really plays into that. And they've experienced all the other risk factors listed above as well. And then one more click, or actually two, because we're going to do autism burnout. Yep. So autism burnout is an intense mental, physical, and emotional exhaustion due to the demands of life overwhelming an autistic person's ability to cope. There's typically a regression of skills, a loss of function. It does vary from person to person as far as what the autism burnout, you know, is for them and how they experiencing it. It does relate to camouflage and masking. They do have much more difficulty managing their emotions, so they're prone to outbursts of sadness, anger, depression, and, you know, anxiety, just any kind of emotions. There's an increased sensitivity to change, which is difficult anyway. Sensory sensitivities can be difficult to manage. and it can lead to suicidal thoughts and behaviors. So now we're going to talk about warning signs. So warning signs are indicating a more immediate risk, while risk factors are characteristics and conditions that make it more likely that individuals will consider, attempt, or die by suicide. Warning signs are that a more immediate concern and risk. There's less research about warning signs compared to risk factors. But one more really important thing to understand is that autistic distress or crisis may not look like neurotypical distress or crisis. In fact, it can look calm and fine, and the words have to have much more weight and much more meaning than outward display of emotions. We do have a resource, Warning Signs of Suicide for Autistic People. This is the international team of subject matter experts who developed this resource over a year's time. We were researchers, clinicians, and autistic people with lived experience. Some people played dual roles. So the purpose of this resource is to explain how warning signs of suicide might be different in autistic people compared to the general population. It's designed to enhance discussions about suicide risk with autistic people. It's not a substitute for professional support or risk assessment. There were 10 research-based warning signs, and then each warning sign had 1 or 2 scenarios that described a real life situation, so you can really understand what's happening for that autistic person and how to support them or what might be concerning. And then there is the research to back it up. So these are the proposed set of warning signs of suicide. They're based on behavior that is increasing or decreasing from a person's baseline or typical behaviors. As you can see, sudden or increased withdrawal. We also have no words to communicate acute distress, which is very much what happens sometimes for autistic people. They can be verbal and they can maybe show some distress, but they go into a deeper crisis and lose the ability to communicate verbally. That marked increase in rate or severity of self-harm, worsening, see these different increasing or decreasing from baseline. There's also the death-related topics that are not of special interest, because many autistic people have special interests of suicide. And then we also captured the perseveration and rumination of suicidal thoughts and behaviors, or, you know, anything that may be really negative experience for them. So these are the ones that are in the toolkit. Next slide, please. So some key reminders when supporting autistic people taken from this toolkit is watch for changes from baseline. Autistic people may not act like non-autistic people in crisis. They may not be able to verbalize their emotions or what they are experiencing. There may be a new focus on death-related topics, and you have to discern between a special interest in suicidal thoughts and behaviors. You have to kind of monitor someone who has a special interest in suicide, because it may morph into their own suicidal ideation. They may research ways to die by suicide. And what may be traumatic for an autistic person could be very different from what causes trauma in non-autistic people. So these are just some things to remember. And now I'm going to turn it over to Caitlin.
Awesome. Thank you so much, Lisa. Just to respond to some of the things I saw in Q&A and chat, this awesome warning signs handout that Lisa's talking about is available. So the group, the working group that Lisa co-leads and has led now for a few years and has made all of these great things, is through the American Association for Suicidality.
Actually, Caitlin, we're not there anymore. Sorry.
Oh no. Okay.
And
They're still working.
And
Okay.
I'll put the website in the chat.
Awesome, perfect. I was gonna say, the best place always to get things is on Lisa's website because they will always be there. Good point. Okay, so just to move forward, I think Lisa already mentioned this really, but our research in this area has really mostly been in the last 10 years. So there's a lot of areas where we're still like not have all of the information as, you know, in terms of autism and suicidality. And one of the other areas where this doesn't come up, that we don't have a lot yet, is protective factors, right? So a lot of times in this field, folks are talking about risk factors, so things that increase your risk, as Lisa mentioned, and protective factors, things that can decrease your risk. We don't have that much on protective factors. As she mentioned, you know, having more social support and connectedness has been one that's been thought about and researched a little itty bit in autism. I think, you know, that's similar to what you see in non-autistic populations when they've, you know, been doing research on protective factors. So I think, you know, granted, we also have to like think about this for autistic people, that it might look a little bit different. It's their perception of feeling supported, their perception of having that social support. And so that may not look like what you might expect for someone that isn't autistic. And their priorities may not match a non-autistic person's, you know, so it may not be the number of people that they have providing social support. It might be one or two really close people. And so those are just things to think about. Okay, I'm going to move forward a little bit and talk about how to ask about suicide and for autistic people or to them. And then some ideas about like questionnaires and interviews that we've used in research and clinical settings, and how best to kind of assess for these things. So first, I'm going to talk a little bit about a couple common communication pitfalls that I see a lot with autistic clients and research participants. And the first one is kind of talking about like a lot of the interviews for suicide that we use in clinical and non-clinical settings have really long multi-part questions. Those are hard to answer for anybody. Like if you're asking 3 questions or 4 questions in one, it is really hard to answer that accurately and to keep track of it in your mind, especially if it's an autistic person. They're going to struggle potentially even more with those questions and potentially get overwhelmed or not be able to answer or not sure which part to answer of the question. And so this is an example, you know, this in the past month here. This question, you know, in the past month, have you had thoughts of death? 1 question. Any thought, any intent or harm to kill yourself? 2 questions. Made any attempts to take your own life? That's 3 questions in one. And this is part of an interview I'll talk about in a little bit that we were using in research. We've realized that this is really hard for autistic folks to keep track of, especially, you know, differences in information processing. So split the question up. We can ask these questions individually, you know, have you had any thoughts about death or killing yourself? 1 question. Any intent, like any, you know, thought that you would want to do this to harm yourself or to kill yourself. And then, have you had any attempts, suicide attempts or attempts to take your own life? So we split them up whenever possible. Another way that misunderstandings occur a lot when you're asking and talking to autistic people about these things is, you know, presenting it in multiple ways can often help. Verbal information being talked at might be not the best way to talk to an autistic person, especially if they're struggling at that moment. We've learned that, you know, having the question written out that we're also asking for them to see can be helpful. Having just some other like general, like a visual of that question can be helpful. So thinking about ways to make this easier when you're talking with folks or interacting with them is really, really important and really key. And if, you know, you're talking with an autistic child or an adolescent, particularly, you want to talk to people that know them well and kind of understand a little bit about what their style is and what works best for them to be able to get that information. Another area where common misunderstandings happen, and again, this refers back to, I think I saw in the chat a little bit about talking about double empathy problem or double empathy theory, which we don't have a lot of time to get into today, but just the idea that autistic and non-autistic people might struggle to communicate and get some wires crossed, so to speak. The way that people define a word can be a little bit different, right? And this can happen with anybody, autistic or not. So, you know, most of the time, if you're doing a clinical interview or working with, like, if you're a provider and you're working with somebody, talking to them and adjusting language is what you do naturally, right? So you use the words that they use, or you follow up and see what the definition is that they kind of use for that word. Autistic participants particularly, or clients, you might really have to adjust to their definition. So it's something to be aware of, right? So here's just an example from a mental health questionnaire. If we're asking our first question, again, that has like 5 questions in one, about depression and experiencing current depression. We had a participant who, you know, if you asked them, if you ever felt down, low, sad, empty, or hopeless, they said no, because I've only felt melancholy. So our interviewer in this case thought about that and was like, okay, so what is it like when you're melancholy? What does melancholy mean? And then when they talked about it in more detail, the participant, they were able to say, you know, okay, these are all things that look like depression, right? I had trouble sleeping. I lost my appetite. I always felt tired. That way, when we're going forward in that interview, if we had just taken that no and not asked any more questions, we would not have gotten the information that we were looking for, which is, you know, have you had this feeling of depression now or in the past? So it's really important, I think, especially when you're, you know, not an autistic person and you're talking to an autistic person, to make sure that you're understanding each other's words and definitions. And I think that could be really helpful. Might slow you down a little, but it's a very important thing to do. The other thing I would say mainly, and this is talking to autistic people in general, but specifically when it comes to suicide, is directness is really, really important. We know that autistic people tend to be more literal and concrete in their wording and how they understand things. So we want to make sure that you are talking about suicide, you're gonna definitely need to talk about it directly and ask that question directly. A lot of times people are afraid, right, to ask those questions, and they are scary sometimes to ask. But if you're asking about suicide indirectly, particularly with an autistic person, they may not understand that that's what you're trying to ask. So you do need to say, are you having thoughts of hurting yourself or killing yourself? You need to say those things directly. If you do something more, you know, removed from that or indirect, often that could be misinterpreted, or it won't get you the clear information that you would like. Another thing I wanted to bring up in terms of assessing and things to be aware of is that there's not really research on this yet. I've seen it and heard from other providers, though, that chronic suicidality, so chronic kind of thoughts about suicide, are pretty common. And as Lisa mentioned before, like, there's also people that have strong interests in certain things too that can overlap with this. So that's also difficult to tease apart. But when I've talked with adults, and this quote is from a participant of ours, I found that, you know, those are thoughts that sometimes reoccur or are happening pretty frequently over years and years. I think some of this is coming, if I had to guess, non-research, but educated guess. I would say it's coming from living in a world that doesn't fit and having those feelings, as Lisa mentioned, of not fitting in, and not feeling like you're being understood. But I think it's something that's important to know and kind of think about, that these things might have been going on for quite a while in somebody, and they might continue to go on for a while, and that's not always in a direct emergency at that moment. We really have to then ask more questions to find out if it's something that is, you know, an urgent concern. And kind of related to that, I also wanted to say that autistic folks sometimes have a different relationship, it seems like, with suicide when they talk about it. So we've had a couple participants say, you know, I just kind of need it there as like an option. So they need, you know, in terms of needing certainty or information in this world, like if this happens, then I do this. They need to know, okay, my options when bad things happen are this, this, and this. Suicide might be that very last option. And so they'll talk about it and say that it has comforted me to have that option, but I'm not going to do it. I think that is something that for me as a mental health provider is really scary, but also important for me to know, so that I know if something is happening, to assess, if those thoughts are getting any closer, or something that is getting any more likely that they are going to enact. We've also gotten people who talk about, if you ask them if they have thoughts about death or about suicide, they say yes. And again, it's this last one here, even if it's not something I'm going to try to do, it just is really interesting. And the idea of understanding what's happening in the body, and we don't know all of those things scientifically, and those things are really interesting to me, like those kind of questions that go more into interests, especially strong interests, are also there. And that's not necessarily a risk factor either. It's just something that we need to be aware of, that like, if this stuff gets brought up, don't necessarily immediately assume it's going to be, a true, like a suicidal thought that deserves more attention. I think is the quickest way to put that. We haven't really talked a lot about self-harm, but autistic people are more likely to engage in self-harm. And so we've also seen in research participants and in clients, like differences in how those might look. So what's difficult is that some autistic people engage in stimming or like self-stimulatory behavior, and that's kind of done a lot of times as a kind of like self-regulating behavior. And sometimes it is hard to know if a behavior that is self-harm looking is actually self-harm, or kind of emotion dysregulation, or is more a sensory experience or a stim. And so there's kind of a difference there that is a little bit difficult to tease out, and you're going to need to ask more questions. I think the quickest way to think about this is, if a behavior occurs, don't assume that looks like it's self-harm. It may not necessarily be self-harm, and you need to follow up and ask some questions about that behavior, and if they can understand why it's happening, or what maybe precipitated it. So one example, talking about sensory experiences specifically, we've also seen like behaviors start as a sensory stim or as a stimming behavior and might be self-soothing, and they might increase in a way that is out of control or not known. You're going to have to ask some questions with people about this. So some of the questions we found most helpful, again, we're doing this research to understand more and to hopefully get good questions. So here's what's working for us so far. When someone has said, in response to a question about self-harm, they say, I often hit myself. Okay, so when does this occur? Does it only occur when you're kind of like emotionally overwhelmed or having a meltdown? Does it happen at other times too? Like if you're more regulated, but you're just angry or upset? And then we ask people a lot if it's for the purpose of harming themselves. And so that's, to me, more of a self-harm, non-suicidal self-injury versus something that is happening because someone is upset. Another way to think about this is, a lot of times people will answer like about punching, not just themselves, but like punching a hole in the wall, right? There's a difference between punching a hole in the wall when you're so upset and you couldn't control your actions, versus I was planning to do that to harm myself and to hurt my arm and to hurt my hand. We tend to try to tease those apart. So I'm going to move on now and talk a little bit about questionnaires and interviews, and what we know seems to work with autistic folks and what doesn't. So this Ask, which is available publicly here at this website through NIMH, or the National Institutes of Mental Health. This Ask Suicide Screening Questionnaire has been studied in autistic people, different settings too, which is nice, both in hospitals, outside of hospitals, in the emergency room. And we've found that it seems to work well for autistic people across lifespan in terms of ages. It's pretty short, as you can see, it's just a screener, and you're asking people, have you had recent thoughts where you were wishing you were dead, or if people would be better off if you were dead, or thoughts about killing yourself, or any attempt. And then you ask more follow-up questions. I think the directness of these questions probably is part of the reason that it seems to work pretty well with autistic folks, as far as we can tell. Other questionnaires we've I have a few. So Sarah Cassidy, again, a group out of the United Kingdom, developed an adapted form of the Suicide Behavior Questionnaire revised for autistic people. So it's that SBQ ASC, Autism Spectrum Conditions. And this has been used with autistic adults in research. And they have it publicly available, again, at this website here. They do say so far they haven't tested it in clinical settings, so we don't technically know how well it can work in different settings, you know, whether it's in an emergency department or in a hospital or an outpatient. We haven't had as many other small studies have looked at other questionnaires, but we haven't seen any extensive testing yet. What I would say is if you are part of a practice or some other organization that uses questionnaires, go ahead and look through them. I would follow up with people who are autistic to see how they responded to the questions and why. We just don't have that information quite yet. So the interview that I've most often seen now, a couple times, both in my research group here and other research groups with children and adolescents that have used, use this with autistic folks, is the Columbia or the CSSRS. This is a publicly available interview for suicide risk. It's meant to be able to be used by a provider, mental health provider, as well as lay people outside of the mental health profession. I will say we have done some adaptations, so I'll talk about them. We found that the items about suicidal ideation, or SI, seem to work pretty well in autistic people for the most part. What we found is also that for each single question that has different response options other than yes and no, we show those responses to folks one page at a time. So if they're in person, we have a binder and have the response options. So like this first one here on the left is frequency of suicidal thoughts. So we ask someone how frequently have you had these thoughts? And how often do they come up? And then we list those answers and say them out loud. So that it's easier, again, for the autistic person to be able to kind of see what the options are. It's also just a lot of words to keep in your mind all at once. And then the second one here on the right is like a version of a question, the answers for a question that asks about how long those thoughts stick around for the person. So if you are having these suicidal thoughts, how frequent or how long do they usually last for when you have them? We found that kind of helps. And honestly, our study right now, we have non-autistic participants and autistic participants. The folks that aren't autistic also like the fact that we have all of these things printed out because it's easier to follow along. So just a thought in terms of making interviews and questions easier if you're using them frequently. Another example of some wording difficulties we've come across. So this first box up here about this question about how likely you are to try to kill yourself now or within the next week. Sarah Cassidy's group, the researcher who has that SBQ questionnaire, found that a version of this question tends to work differently in autistic folks. They were more likely to endorse killing themselves at some point in the future. And I think their question was like, not within the next week, but ever. Would you ever kill yourself? And autistic people are going to get more of that possibly response due to literal thinking, right? To that concrete style. And they're like, well, I can't predict the future, so maybe that will happen in the future. I'm not sure. So it's just important to kind of think about the questions that don't have necessarily a time frame or some sort of concrete feature to them, and it can be really hard. We found this similarly with the Columbia and this version here down on the bottom. So this bottom box here about this last question, have you done anything dangerous where you could have died? We have gotten a lot of yeses to that question. And then when we follow up and ask, it is not a suicide attempt. It could be, I wasn't paying attention the one day and I crossed the street without looking, but I wasn't trying to do that. Okay. So it's important to think about these have you ever or will you ever questions a little bit more specifically and follow up with people to make sure that they understand what you're trying to get at. Definitely important. Another version of visuals, I saw in the chat, one way that we've handled this is like This is what we use for our interview for the first part on suicidal ideation. And we use this to kind of guide the interview. So we used a visual thermometer to say, we're going to ask you questions about the past 6 months and then ever. And the past 6 months, we have a calendar and we'll highlight, you know, from the day that we're starting until yesterday for those 6 months. And we go through and say, all right, we're going to start by asking these questions as we go up the scale. So we're going to start with, you know, more passive thoughts about wishing you were dead or not alive, having more active thoughts about suicide, and then talking about, you know, method and intent and things like that. So we move our way up. We found that this is really helpful to guide people along to that interview. And I find that that can be really helpful to keep people kind of focused in on what we're wanting to ask. And it helps us honestly to go back to them and be like, all right, so we've asked these questions like 1 and 2 and 3. And so now we're going to move on. But sometimes, you know, you get into a conversation and you're following up and you kind of need to go back. Okay. So we're almost done here. We wanted to make sure we had a lot of time for questions. I wanted to say that the couple main points, if we could boil this all down, and we've overwhelmed you, which I hope I haven't, but we want to make sure that folks know that autistic people are a risk group for increased suicidal thoughts and behaviors. We know that they're more common among autistic people. We want to also say that, you know, the risk factors or the warning signs that autistic people have can be the same as non-autistic people. So what we already know as risk factors, just generally. Or they can be unique to autistic people, like Lisa mentioned with masking or camouflaging or feeling autistic burnout. Those are things that are different and unique to autistic people. Or like she said, you know, an adult diagnosis, what we seem to see as a risk factor. So there might be some things that are unique. We might be adding to this in the future as we do more research. But it is important to know that there are some things that are similar and some that are unique. We also think it's really important to know that autistic people may not display physically the same signs of distress. As Lisa mentioned, you know, people might look really calm or even flat, but that doesn't mean that they're not experiencing a crisis. So it is important to ask those questions and ask them directly. That leads to our last one, right? So make sure that we're being direct when we're talking to autistic people about suicide, and follow up, ask more questions to make sure that you're talking about the same things. Those are the 3 things I think, if I could distill it down. I wanted to make sure that there's resources here. We'll make sure we give our slides over to Forefront so that they can make them available. I know they also make the video today available. So these cool, awesome toolkits that Lisa and her work group have used are at her website. So that's autismcrisissupport.com. And if you look under resources section, they are there. I always use these, whether I'm presenting with Lisa or not, because they are amazing and really helpful for folks. We've been giving the 988 information sheet to folks when they are in our study and display any sort of suicidal thoughts. And it talks about what 988 does. There's all sorts of other ones there, including the warning signs one that she talked about today. I also listed some information about safety plans. There's a group in the UK that made a very in-depth, publicly available version of a safety plan for autistic folks with more visuals. I don't know. I mean, for me, in my work, I already have to kind of use a specified safety plan for someone that has suicidal thoughts and behaviors as part of our, you know, medical center. So I build in those things like the visuals. So those things are available. And there's also some information here in a paper and a colleague of ours who talked about adapting safety plans for autistic kids. So, you know, kids or adolescents that are in mental health care, but want a safety plan to talk about what to do in moments where they are feeling overwhelmed or in crisis. Okay, so I'll leave it from that. I provided my email here and Lisa's website, which also has a way to contact her, as well as my lab's website. So if you ever interested in other information or resources, but I will take it from here to answer some questions. Thank you.
Wow, thank you so much. I learned a ton. I'm sure we all learned a ton. This was just really helpful. Thank you, both of you. We have a ton of questions, so let's see how quickly we can go through these. And I don't know, Lisa and Caitlin, if you can stay beyond the top of the hour or not.
I can't.
You can't.
Yeah, I can.
You can.
No, I
Okay,
will be
great.
okay.
So maybe we'll take like 5 extra minutes to go through some of these. So let's see how many we can get through. So first question I'm seeing in the chat here, Joel asked, is there something unique about the way that autistic people think and communicate that makes them more at risk for suicidality?
Hmm. I am torn. So I think research-wise, we are not positive on a response to that to have an answer. Okay. So I'm going to say I don't know from a research hat. If I had to predict, and Lisa can join in on this too from her life and live experience on this, I would say it's maybe not entirely unique. It is a function of being autistic in a non-autistic world, if I had to guess, right? So just living in a world, I didn't include this. I do in other talks if I have the time, but I like to think about this when I'm thinking about other mental health conditions, even in autism, is like, there's a whole lot of things, maybe genetically or other things that are going on. And sure, we can talk about all of that. And that's what our field has done for the last couple of decades. There are a whole lot of other environmental things that are very important. And one of those is autistic people are living in a world that is not built for them. They are kind of, the old way that I used to talk about this with families was saying, oh, your kid just has a different operating system, right? Like the rest of us are Android and your Mac, and that's okay. The issue is like sometimes those things don't communicate well. So
Yeah.
that's my short answer.
Yeah. Next question down. Did Forefront, Caitlin, and Lisa attend INSAR in Seattle this past week? We were talking about this beforehand. I did not. I was actually in the UK visiting family. Caitlin was unable to attend. I wasn't sure if Lisa was able to attend or
I
not.
wasn't.
One of my colleagues was there for a day. He's not here today.
Yeah. And Lihia Antanzana that you mentioned there is actually here at Pitt, and she is
fantastic.
several doors down right now.
That's great.
So yes,
That's fantastic.
we have some overlap, but yes, the International Autism Research Conference was in Seattle this past week.
Yeah. Do you think many people with borderline personality disorder may be undiagnosed ASD, considering criteria of frequent SI/behavior and unstable sense of self?
This is a good question.
I think typically it's the other way around, where autistic females are diagnosed with BPD. There's a lot of similarities, but you really have to look at the intention behind the behaviors to distinguish between the two.
I agree, fully.
What is the best approach to encourage families to support a family member who is wanting to seek out resources while dealing with suicidality?
We don't have like an evidence-based form of this. I would say it's important to make sure that you are providing that social support in the way that the person would like, right? So believe them, be there, listen, help them seek out resources if that is what they would like help with that. Probably pretty similar to a non-autistic person, if I'm being honest, right? I don't know if there's other things to add there.
Does female as a risk factor include trans women or just people assigned female of it?
There's not a ton of research yet looking at trans and gender nonconforming folks. It's starting. I don't know if you've seen any on this yet, Lisa. A little bit. Looking at this in suicide and autistic people. So autistic people are more likely to be LGBT in the first place. We do know that. And I would say we don't have full information yet looking at female sex assigned at birth versus trans or gender nonconforming yet. The reasoning I would use, and hopefully our study can help do this because we've had a lot of folks who are trans and gender nonconforming. So we will be able to look at this hopefully. I would say my assumption, my guess is that they're going to have a heightened risk being trans or gender non-conforming, even compared to other autistic folks.
If someone has a special interest in suicide, how can we support them in therapy to not let that special interest increase their risk over time?
Question. I think I have a hard time. I wonder, it depends on the kind of focus of this interest. So I've worked with folks where their interests are different types of weapons. So I'm thinking in that term first. I mean, that's obviously, you know, what you guys already provide at Forefront. It sounds like, you know, helping people be educated about safety, keeping things secure and safe, and locked up as needed. And I would probably just continually check in, you know, with the person, which is kind of how I handled that, making sure that, you know, their risk hasn't otherwise increased. I don't know, Lisa, if you have other thoughts on other ways that this.
I mean, I would just directly ask them, has your special interest turned into suicidal ideation for you? Autistic people tend to be very honest. They answer direct questions. I would just ask exactly what you want the answer to.
Very good quality, I think. But yeah, I agree with that.
That's really helpful. Is there a version of the questions? I think these are the questions that you were reviewing, Caitlin, broken down in a PDF for professionals to use. I can see this being helpful, not just for autistic, but for many people who struggle with multiple question statements.
We have them. If you want to email me, I'll provide them. I'm going to be working on writing this up so that we do make it publicly available. But I like that idea of also putting it on our website as something that we
I love that
give to
idea. Maybe
folks.
we can link to it when you've done that as well.
Sure.
That would be really great.
I have to go at 4 o'clock, but I just want to answer that I've seen somebody, somebody's question either in the chat in the Q&A asked, does this stuff, these interventions, for lack of a better word right now, help autistic people and the general population? And absolutely yes. Whatever, you know, this helps everybody. Slowing down, asking direct questions, it helps everybody. But thank you. I do have to leave at the top of the hour.
Much appreciated. Thank you so much, Lisa. It's a pleasure. Okay, let's Caitlin, can we take like a couple more and then we'll be done?
Absolutely.
Yeah. So I'm just looking through, we have so many questions here. I think we just sort of talked about that one a little bit. Resources for assessing risk with non-speaking autistic people.
This is an area that has been lacking, and I'm hoping it's getting better. I would say there's a few, I've seen some work that hopefully will get out published soon. Kennedy Krieger that has, it was one of the study that I think with the same people that Lisa mentioned, have been looking at making more visual based measures, and those could be useful. And they're, you know, looking at kids, specifically autistic kids, having those kind of measures available, both in trauma settings, suicidality, things like that. I think those kind of things could be potentially really helpful here, having those visuals available, but I don't think they're publicly available yet. But I do think that we need those things.
Yeah.
We've talked about it quite a bit.
Yeah, that makes sense. Okay, there's one here that I am going to answer as a Washingtonian, if that's okay. Several countries have medically assisted deaths. The UK is considering this. I've been following that. My family's over there. How do you deal with clients who want to pursue this? Although autism on its own is not a medical condition, health condition. I know several 20-something autistic people, mostly female, have obtained it. So I'll just say something and then I'll hand that over to you, Caitlin. So here in Washington State, we've had death with dignity, we call it, for a long time now, and you know, the laws and the regulations around that are very clear around terminal illness within X months. So I have not read much about that being an issue. I haven't read anything about that being an issue here in Washington. But obviously, depending on how those laws are enacted, that potentially could be a question. Sure.
Yeah, I don't have much to add. I've been watching the news on this too, but I haven't seen too much yet.
It
It is upsetting to people when I
is
see it.
upsetting. It's a really
Right.
tough issue. It's a really tough question. Have you considered the overlap with perimenopause? Age 50 to 55 sees a
Such a
peak
good question.
in assigned females of Earth.
I know a researcher to connect you with, if you're interested and you want to email me, who's actually at INSAR. I was just talking about this with a couple colleagues. Rachel Mosley in the UK has looked at these topics, I think separately, like menopause, perimenopause, and suicide and self-harm. So she might be a perfect person to talk to. I think I have heard these things from autistic women in that age group and talking about those things. And I'm so interested to know more. And I think that's a really good area to go into.
Yeah. Can we do like one, maybe two more? Mom of an autistic child worried to miss any signals because I'm too involved. Support for parents.
I think the most, I don't always want to like freak out parents or loved ones of any age with these presentations. The thing I think that Lisa brought up that is in the warning signs document that I find the most helpful is think about change from baseline, right? You know your kid, you're the expert on your kid. If you see something that is a major change. Now, granted, there are also just changes that happen as someone ages. I wouldn't say every, shift in interest or anything else is always a cause for concern, but like those are things to pay attention to and to see if you can find out what's going on. Those are the things I think are most important. And I think that's not that dissimilar than anybody, but I think for autistic folks, it's really important to look at, are there major changes from their usual baseline self?
That makes a lot of sense to me as a parent, like how my kids' behavior is different from how they normally have been. There are several questions here. Let's do this as the last one about 988 and the experience of autistic individuals contacting 988. Comments on that?
It's hard. I like that Lisa and her group have worked on this and making it just understanding what the process looks like when you call a 988 and what it's going to be like. I've also worked with some clinicians here who have like called the local crisis hotline, like the crisis network here in our county, so that you can see what it's like ahead of time. I do understand people have had negative experiences with those and with 988. I think it's important to recognize that we don't necessarily know the level of training that anybody working at 988 who's going to answer the phone has with autistic folks, and whether they are going to be able to be the most helpful in that moment. I love the idea. I saw in the chat there that, someone is trying to build separate crisis resources for autistic folks. And I think that's wonderful.
Yeah, I think that's a wonderful thing. Yeah.
Yeah, absolutely.
Okay, we have gone way over on time, so I'm going to stop right there. I apologize to everyone whose questions we couldn't get to.
I'll write up answers if you want me to.
So many questions. We are recording this. We can probably look at the Q&A afterwards and see if people do have questions. You can email Caitlin directly, or you can email us. You can contact us through the contact form on our website. Let us know in that message that you're following up on this, and we'll make sure that we collate those and get some answers if we can.